Hello, my name is Christiana Dinah, and I'm a consultant ophthalmologist at London Northwest Trust, where I specialize in macular diseases. My talk today will be introducing you to the macula, which is a specific area of the back of the eye, and some of the common diseases that affect it. So, the function of the eye is to allow us to make sense of our surroundings. In order to do this, we need light. An eye that is organized to process that light and pathways in the brain that make sense of the information arriving from the eye. So today what I'll be doing is explaining how the macula, which is a specialized part of the retina, works. And I'm also going to highlight two diseases that affect it and some of the ways in which current treatments have helped to preserve sight. I hope this talk will leave you feeling hopeful for what is to come and more empowered for the future. So let's talk about the eye. The eye is a small but impactful organ. With our eyes, we process millions of pieces of information at lightning fast speeds and turn them into simple images we see instantly. A good way I like to think about the eye, and I speak to my patients about the eye, is that you can think about it similar to a camera. In fact, the human eye is part of a classification of eyes known as camera type eyes, same as most mammals. So jellyfish or starfish, for instance, they have eye spots which just signal lightness or darkness to the brain. Just like a camera, the human eye cannot function without light. Light enters the eye through the pupil, which is the brown black area that we all have, which acts as an entryway of the colored part of your eye, the iris. The pupil gets bigger or smaller depending on how much light is needed to enter your eye, and then the light hits the lens. The lens helps focus the image you're looking at onto your retina. So you can think of the retina as the film onto which the image is projected. And this is an image of the retina. So the retina lines the inner surface of the back of the eye. There is a small specialized area of the retina called the macula. And this macula is approximately 5 millimeters in size, which is about the size of a small grain of rice. At the very center of the macula is a small pit called the fovea. It has the most nerve endings, or what we call photoreceptors, cells that are crucial for sharp, clear vision when looking straight ahead and to see our world in color. So when you're reading text on a page, telling the difference between faces, small movements in front of you, these are some of the things that your macula helps you to do. This information is transmitted to the optic nerve, which is connected to your brain, where we make sense of what we're seeing. And I've just drawn a circle around the macula and also around the fovea. Now, the retina is made up of specialized cells. In particular, the photoreceptor cells are the light-sensitive cells. They're the ones that detect light. There are two types of photoreceptor cells. One is called a rod, and the other cone. And this is basically based on the shape of these cells. When light strikes the photoreceptors, they're activated and they fire off electrical signals along a series of nerves all the way to the brain. The rods process black and white light and help you see at night and in dim vision, sort of like dusk, evening vision. The human eye has over 100 million rod cells. The cone photoreceptors process color and detect fine detail. And the human eye has approximately 6 million or so cone cells, and most of these are concentrated at the fovea, the pit I mentioned earlier. So that's the rod. We're pointing with a red arrow, and in a purple arrow, highlighting the cone cells. The RPE, the retinal pigment epithelium, is the pigmented cell layer that is tightly attached to your photoreceptors and nourishes them. I describe them often as, special friends. You can think of them as special friends because they're meant to be together, they're tightly bonded. or besties, as my daughter would say. The RPE has many very important functions. I'll focus on three of them. It absorbs scattered light, which increases the quality of the visual system. It supplies nutrients to the photoreceptors, and it also helps to eliminate to eliminate water, I should say. The RPE gets rid of waste products generated by the photoreceptors. So it helps to keep this visual system functioning optimally. The choroid is the spongy layer of blood vessels that the RPE rests on, and it provides oxygen and nutrients to your RPE and photoreceptor layer. And so you can see that the structure of the macula is very intricate, very detailed, very organized, much like, say, a Roman military formation, where you have centurions and standard bearers and legionnaires. This structured organization is really important to ensure detailed vision. And any disruption to this detailed structure affects the quality of the image that we see. So in 2024, we can't really talk about the structure of the macula without talking about OCT, or optical coherence tomography. OCT is a scanning technique introduced to the eye clinic approximately 20 or more years ago, and is now even available in many high street opticians. Using reflected light, it allows us to see the microscopic structures of the macula by taking a quick picture of the back of the eye within seconds, without needing to expand the pupils. This is commonplace now, but truly revolutionary, because we couldn't really analyze the RPE, choroid, photoreceptors as easily as we do now without the OCT. This means that, if you take even a casual walk by any eye clinic in the UK or even an optician, you're very likely to have an OCT done. It's so quick, painless, and informative. I've got a picture of an OCT scan, which is taken just through one layer of the macula, precisely over where the fovea center is. And there's a yellow arrow that is pointing out the RPE, which we highlighted earlier as that special friend that acts as a basement layer for your photoreceptors. And on OCT, it's the brightest, whitest, outermost line on the scan. And then just above that, you have the photoreceptor layers, and which is highlighted here with a red arrow. And then you can see the central dip that looks like a valley, where the blue arrow is pointing at, and that's your fovea. This is the area with the highest concentration of cone cells, which are responsible for color vision and the sharpest quality of vision. The macula also has a network of fine blood vessels passing through it, closer to the surface. These are like secure tunnels, or should I say pipes, channeling blood. And when a disease affects these blood vessels, they can become leaky and allow the contents of the pipe to seep out into the retina and cause disorganization of the carefully ordered structure that we've just discussed, and impair the ability to see in detail. So a more advanced version of the OCT has recently entered the clinic, say in the last 5 to 10 years, called OCT angiography, which allows us to see the OCT structure, the structures we mentioned via OCT, but also an impression of the blood vessels as well. And also this scan is also conducted in clinic as simply as the other OCT. So we now have this access to a lot of detail, just in seconds, really, within an eye clinic. Now, how does the macula work? If we think of the whole retina as processing information like a lawn sprinkler, water everywhere, the concentration of cones at the macula, particularly at the fovea, means that area processes information more like an eyedropper, in a very detailed fashion. And when the macula is damaged, there is still vision, but it's more blurry and lacking in detail, particularly when the fovea is involved. So in summary, we've just discussed the eye as a camera, The retina as a thin layer that lines the inner aspect of the back of the eye. The macula is responsible for detailed vision. Photoreceptors, RPE, and choroid are crucial cells that help us to interpret the images that we see, and they're organized in a very structured way to enable us to see things in a lot of detail and in color. The macula also has blood vessels within it, which can be affected by disease. So the next segment of this talk, we will look at a leading cause of sight loss, especially in those aged over 65 and above, but really from about age of 50, called age-related macular degeneration. Now, whilst the exact cause of age-related macular degeneration is unknown, these factors increase the risk of being affected. Increasing age over the age of 50, smoking, European descent, diet, and family history. So, in terms of age-related macular degeneration, there are subtypes: early, intermediate, and late. We already discussed the organized structure of the outer part of the retina, the RPE, photoreceptors, the choroid. That's the region of the retina that is affected at the macula when age-related macular degeneration occurs. Now, early age-related macular degeneration essentially is where you see yellow deposits known as drusen collecting under the RPE. Remember, I said that the RPE, the choroid, and the photoreceptors are intimately connected, they're besties. However, these yellow deposits separate the RPE from the underlying choroid, which, as we learned earlier, provides nutrients to the photoreceptors and the RPE. This prevents nutrients from getting to the photoreceptors and waste from being carried away. The RPE and its special friend, the photoreceptors, they become stressed and stop working properly. The blood vessels of the choroid also become thinner and shrink, and these deposits make the RPE layer appear bumpy on OCT. Many people with early age-related macular degeneration do not notice any symptoms, although there may be issues such as difficulty seeing in dim light or low lighting, colors may not seem as bright, and then there may be some difficulty with seeing things as sharply as before. And this is a scan, an OCT scan, and you can see the bumps instead of the straight lines that we had before of the RPE and the photoreceptors. You now have sort of bumpy waviness where that was straight before and clean. And if things continue to progress, there is the age-related macular degeneration becomes moves on to a stage called intermediate age-related macular degeneration. And at that stage, the collection of drusen, those yellow deposits, they get bigger, they increase, they join up, and that results in more damage to the RPE and thinning of the photoreceptors and the choroid. Some people with intermediate age-related macular degeneration become aware of straight lines appearing wavy, what we call distortion. On OCT, you can see the bumpiness of the RPE layer becomes much larger than what I'd shown you before. And in terms of treatment for early or intermediate age-related macular degeneration, there's currently no approved treatment. However, there is evidence that specially formulated vitamin supplements that have been tested in a study called the AREDS2 study may reduce the risk of progression from intermediate stage to late stage AMD or macular degeneration by around 25%. So we tend to recommend the AREDS2 treatment about that stage. Then the final stage of age-related macular degeneration, the late stage, is divided into two types. There's the geographic atrophy type of late macular degeneration, or the wet age-related macular degeneration, which is also a form of late macular degeneration. So geographic atrophy is the advanced form, is one of the advanced forms of age-related macular degeneration. And it's a type of advanced dry macular degeneration. In geographic atrophy, as the RPE and photoreceptor layers get thinner, which we described, and the choroid shrinks, you start to get complete loss of photoreceptor and RPE layers. So they're just not thinner, they completely disappear. They shrink and then they disappear. In most people with geographic atrophy, this area starts small and away from the fovea, within the macula, but away from the fovea, away from the center, and slowly, over a few years, progresses to involve the very center. Now, before the fovea is involved, the ability to read letters on a chart may be preserved. So typically, when we check your visual function in an eye clinic, there's a chart that you read through, you read down, and your clinician might ask, can you see this letter? You mention the letter and so on. We call these our vision charts. And really that is measuring the function at the fovea, at the very center. Now, because geographic atrophy tends to start away from the center in at least approximately 75 to 80% of people, oftentimes you can have a large area of geographic atrophy progressing, but you can still read right down to the bottom of the chart because the fovea is spared. And that may allow people to think your vision is good or your visual function is good when you might actually be really struggling, particularly if both eyes are involved. I should also highlight at this point that about 20% of people will have geographic atrophy starting right at the center, but most people would have it starting away from the center. And even when the center is not involved, tasks like reading or driving may be involved before the center is involved as geographic atrophy progresses. Autofluorescence is a type of retinal picture that helps us to highlight areas of geographic atrophy. And we use this test in addition to OCT to help really understand which areas of the macula or retina are involved and how significant the problem is. On autofluorescence, the black areas are the areas where the RPE and the photoreceptor cells are no longer present. So that is an area of geographic atrophy, while the quite bright white areas are the areas that are likely to become black soon. So they're at risk of becoming black. And then the other areas tend to be spared or preserved retina. So it's a fairly easy scan to read because black means geographic atrophy or loss of cells. White, in this context, white means these are the areas that are at risk, and then the rest of it is, preserved retina. And the fovea is pointed out there in yellow, and an area of geographic atrophy circled in yellow as well. Now, factors that increase your risk of geographic atrophy. Age is a significant one, probably the most significant, with the rate of geographic atrophy quadrupling for every decade of life, to the point that around the age of 90, 20 to 25% of people, between 20 to 22%, will have geographic atrophy, particularly in a Western population. Ancestry is also a significant risk factor, and by that I mean people of European descent have a higher risk of geographic atrophy, and it's more common here, whilst the rates are quite low, we think, in Africa and other regions of the world, although research in those areas is not as advanced, so it's possible that the rates are not as low as we think, that there might be some underreporting. Now, those factors I just described, ancestry and age, you can't do anything about. That's out of our control. But factors that increase our risk of geographic atrophy that we can control include smoking, which increases risk by 3.5-fold, diet, and basically having a diet with fewer portions of fish, vegetables, and fruit, depending on your genetic risk, can increase your risk of geographic atrophy by 2 to 2.3 fold. So those are the things we can potentially modify. Now, how does geographic atrophy develop over time? As I said, in about 80% or 75 to 80% of people, it starts away from the center. And this picture here is depicting how it might progress over time. And this is from a paper published in 2018 by a group in the States. And you can see that the yellow area is depicting geographic atrophy. And over time, typically, this area starts to expand and expands in a sort of circular pattern until it completely encompasses the macular area, including the fovea. And at that point, you might then notice a significant drop in performance on the letter chart, but particularly in people where this is happening in both eyes, the struggle with visual activities, daily activities that are vision dependent, can happen much earlier before the very center is involved. And the average time to having the center involved in many studies is around 2.5 to 3.5 years, whilst the time to having both eyes involved, sort of average time, median time, is approximately 5 to 7 years. I should emphasize again that geographic atrophy is actually quite a varied disease. Saying geographic atrophy is present doesn't tell us how big the area is. You could have a very small area of geographic atrophy and it's still geographic atrophy. It doesn't tell us how close to the center it is, and it doesn't tell us how fast it is growing. So there's a lot of research ongoing to try to sub-classify or subdivide geographic atrophy, because it's really like saying I've got a watch. That could be a Rolex, or it could be a Swatch, or it could be a toy watch. There's different types of geographic atrophy, and there's a lot of research trying to delineate that. So these are examples from my clinic of my patients, anonymized, of course, but you can see the area of geographic atrophy here on the left. The black areas are fairly small, and within 4 years, you can see that's expanded, and the very center is involved, and the vision is significantly lower as well. Whilst this is another patient of mine over almost 5.5 year period, and you can see the black areas of geographic atrophy, and over 5 years, the black area is a little bit bigger, but not that much bigger. So, both have geographic atrophy, but one is growing at a very, very slow rate, whilst the other is growing faster. The other facts I should emphasize, I think I mentioned this earlier already, is that the average time to both eyes being affected is approximately 5 to 7 years, 6 years. And the ability to read down the letter chart may be all right, fine, whilst day-to-day vision may feel much worse. So it is important that you explain your experience at home with your vision and the activities you like to do to your clinician, so that that can be taken into account. We haven't got treatment in the UK for geographic atrophy, but last year there was a breakthrough with a new treatment called Syfovre being approved in the United States as the first treatment for geographic atrophy last year, February. And another treatment was approved in August in the United States as well for the treatment of geographic atrophy. Both treatments are delivered by injection into the eye, either monthly or every other month, and they don't reverse geographic atrophy or stop it from progressing, but they do slow down the rate at which it grows by 15 to 20%. And I guess you can think about that as, if it takes approximately 5 years, say, in a particular person, for the geographic atrophy to affect the center, potentially these treatments might be able to slow that down by approximately maybe 6 months or 9 months, somewhere there. Many trials are ongoing with potentially promising treatment on the horizon. different opportunities out there now for clinical trials of treatments for geographic atrophy, some that are tablets, some are regular injections. There's even teams looking at eye drops. But ultimately, the field is now expanding and there's a lot of focus on this. So I'm very hopeful that we will have more treatments coming through the pipeline into our clinics in the near future. To switch tack now to wet macular degeneration. This is another form of late age-related macular degeneration and occurs in about 20% of people with age-related macular degeneration. And in this case, the stressed RPE and photoreceptor cells of the macula gather and recruit other cells that promote growth of leaky blood vessels. And so you get abnormal blood vessels growing from the choroid through the RPE or under the RPE and leaking and causing a disorganization of that structure that we highlighted earlier. And that can cause blurred vision, straight lines appearing bent, so distorted, and just general blurriness. These leaky blood vessels, as I said, yes, cause disorganization, and that's what's highlighted here. And if this is not treated promptly, this can lead to scarring and shrinkage of the photoreceptors and irreversible central vision loss within months to a few years. In the United Kingdom, when we have the NICE guidance that has recommended treatment with anti-VEGF therapies, which are meant to be started within 2 weeks of presentation or of referral. And these treatments have significantly reduced the rate of sight loss or blindness due to wet macular degeneration over the past almost 20 years since they've been introduced. And this is a scan of someone with OCT scan of someone with wet macular degeneration. And you can see that the fovea, which is supposed to be like a valley, now looks like a mountain. And the straight line of the RPE is not straight, it's very wobbly. And there's a lot of fuzziness in that area. So I've highlighted this. These are the treatments that we give. We find that vision improves within 2 to 3 months of regular monthly injections. And most units will give at least 3 injections to start with on a monthly basis, and then start to extend the interval at which the treatments are given. And after the initial rise of vision, the rapid and substantial rise in vision within 3 to 6 months, the injections after that point is really to maintain the vision gain. So you probably won't notice improving vision beyond 3 to 6 months. But what we're then trying to do is maintain the vision that has been gained. And oftentimes that is a long-term plan and long-term treatment. We call these intravitreal injections, which means to place the medication directly in the space at the back of the eye, the jelly-like fluid called the vitreous cavity. It's important to note that these treatments, like I said, result in rapid increase in vision within the first 3 to 6 months, and then we just maintain vision after. So just to summarize this segment, age-related macular degeneration can be divided into early, intermediate, and late age-related macular degeneration. We discussed that a balanced diet can reduce the risk of advancing to late AMD by 25%. And by that balanced diet, I mean that and AREDS2 supplement. Late age-related macular degeneration can be divided into geographic atrophy or wet age-related macular degeneration. We now have 2 new treatments that have been approved for geographic atrophy in the United States, and in the UK, they're still being considered by NICE. But meanwhile, we do have multiple treatments in clinical trials that we're hopeful will deliver treatments to us for our patients soon. With regards to wet macular degeneration, we've advanced leaps and bounds over the last 20 years or so with treatments now that have helped reduce sight loss by at least 30%, with fewer injections than was initially needed, with more durable treatments now available in most clinics across the UK. I will now go into the final segment on diabetic macular edema. Now, approximately 400 and just over 400 million people in the world have diabetes. It is officially a pandemic. And diabetic macular edema is the most common cause of sight loss in people with diabetes. It is a complication of diabetes, with about 1 in 15 people with diabetes developing diabetic macular edema, affecting about 20 million people worldwide. However, only a small number go on to develop severe visual loss from it. Now, why does it happen? In diabetes, the body struggles to deliver sugar in the bloodstream to the cells that need it for energy, and so we have high blood sugar levels. These high blood sugar levels are toxic to the pipes. Remember, I said the small blood vessels are like pipes that run through your retina. High blood sugar is toxic to those pipes. Those pipes are typically fortified by foot processes that just keep them nice and strong, and the sugar damages this foot processes and causes them over time to leak. And this leakage causes sort of swelling and disorganization of the structures we described, and you that then results in blurred vision. So on the left of the image, in the image, you can see a scan, an OCT scan of diabetic macular edema, and the large sort of black areas, this should be the valley we discussed earlier, the pit, the fovea. Instead, we haven't got a pit. That's been disorganized now with these black areas, and that's fluid. And that's basically macular edema, in this case, diabetic macular edema. You can also see that you can imagine that the light being focused on the fovea, instead of going directly now to the photoreceptors, will be interrupted and scattered and blurred. Now, how do we treat diabetic macular edema? Improvement in diabetic control and blood sugar control helps to promote clearance of this leakage. However, we've had laser treatment as a treatment for diabetic macular edema for over 4 decades with good results. But when the center of the vision is involved, the benefit of laser is limited. So instead, in that scenario, we now have intravitreal anti-VEGF treatments or injections similar to what's used for wet macular degeneration. And we found that they also help in diabetic macular edema to seal up those leaky blood vessels and allow the fluid to be pumped out of the macula, and restoration of the anatomy or the architecture of the macula. Intravitreal treatment with steroids also work to clear the fluid, and we tend to deliver this as an implant once in 4 months in most patients with diabetic macular edema, and it also helps to clear the fluid because inflammation also contributes to the leakage that happens in diabetic macular edema. So this is one of my patients, and you can see on the left there is a red arrow pointing to an area of redness within this map. So I'll just talk you through this picture. The big blue circle is basically denoting the macula. The small one within it is the fovea, basically, the 1 millimeter of the fovea. And we like this color to be more yellow and green, which means the thickness of the retina is, around 250, maybe 300 microns. The redness that you're seeing is denoting thickness, and so fluid leakage in that area. You can see it doesn't affect the center. So I applied some laser there, and let's see, that 6 months on, you can see that redness is significantly less now, and far from the fovea, no longer threatening to go that way. So that's a great result. And this is the scan in that eye, in another patient, treated with 4 intravitreal injections over 5 months. And this is after treatment. You can see the fovea, that pit, which you couldn't see here due to the distortion. And we chose to treat with injections here because, as I said, when you have leakage at the center, laser is not suitable. and injections work brilliantly to help to restore that anatomy. Before I summarize here, we also have recently published a nice guidance on diabetic retinopathy, which includes diabetic macular edema, and that highlights how to monitor, when to treat with laser, when to treat with injections, when to treat with surgery, because rarely sometimes that's needed as well, and also goes into the most cost effective treatments and essentially sets the standard for achieving best standard of care for patients with diabetic retinopathy and diabetic macular edema in the UK. There are other diseases that cause macular edema. Retinal vein occlusion is one. Some inherited retinal dystrophies are others, but we won't go into that today. Suffice to say that the macula is clearly a very important structure for sight, and there's treatments for a lot of diseases and treatments in the pipeline for more to come. So to summarize the diabetic macular edema aspect, diabetes is a very common disease. Diabetic macular edema is the most common cause of sight loss in diabetes. We commonly treat diabetic macular edema with laser or intravitreal antivascular endothelial growth factor treatment or steroids. There is ongoing work to increase the time between treatment, and we have new treatments that have been approved now that enable us to give patients fewer injections to maintain the architecture. And there's new treatments in development that might require just a single injection through gene therapy, amongst other mechanisms, implants, to reduce the burden of treatments yet preserve vision in patients with diabetes. So to summarize this whole talk today, we've talked about the organization of the macula. We've talked about two common diseases that affect the macula: age-related macular degeneration and diabetic macular edema. We highlighted recent treatments available for these diseases and the availability of trials of promising treatment in these diseases coming to a clinic near you, hopefully soon. Thank you very much for your attention.